I'm Anwesh. I'm a medical student at University of Tennessee Health Science Center. I'm in my fourth year applying to internal medicine this year. And I saw this patient in my internal medicine rotation, actually. And so we're going to talk a little bit about malignant mesotheliomas, in particular about malignant pleural mesotheliomas. So mesothelioma by itself is a pretty rare condition. There are probably about like 3,000 cases every year. And 94% of these cases tend to be the pleural kind of mesothelioma, although you can get mesotheliomas in other connective tissues like peritoneum. Clinically, it generally presents with non-specific symptoms just because it's more of a mass kind of mass burden related symptoms. So people get shortness of breath, but it's not quick onset, it's very insidious onset. So, and you can get coughs and you can get pleural effusions, all of which can lead to some symptoms. And other than that, you'll have the other normal cancer symptoms like weight loss. So pleural mesotheliomas are not very well known to like invade into anything. They just kind of tend to stay there and they eventually result in numerous pleural effusions. So we had this patient, she was a 70-year-old female. She did have a past medical history of breast cancer, status was lumpectomy. And on the same side, actually, she presented with chest pain. And this chest pain, she said, got worse over about a year or so, but she didn't initially think much of it. And then it got like sharper. So she went to like multiple outpatient clinics. And in these outpatient clinics, she was diagnosed with shingles. And they initially thought there was no rash, but the thought was maybe it was some sort of internal shingles, which is what led to the delay in her diagnosis. So sorry, guys, my voice is a little rough today. And so she kept getting treated with gabapentin and for post-herpetic neuralgia, and which delayed the diagnosis further. And eventually she came in because she got worsening of breath symptoms, shortness of breath, and eventually she was sent in for some imaging. And as you can see here, the X-ray shows the original imaging, massive pleural effusion with some right basilar atelectasis. And that led to a thoracentesis that was complicated by a hydropneumothorax, and a chest tube was placed. And then the patient underwent VATS, which then eventually revealed a thickened pleura. So we saw this patient after this VATS process, and we were mainly consulted for medical management, pain management, and controlling her pain was actually very, very, very difficult because we tried a lot of medications. She was kind of elderly, so which led to a lot of altered mental status symptoms. Eventually, the only thing that really helped her was an intrathecal pump that we resorted to after plenty of other methodologies were tried. And she, in the meantime, the pleural biopsy did show MPM of the biphasic histologic subtype. And we attempted opioids, fentanyl patch, anticonvulsants, all of it failed. And the intrathecal pump eventually gave her some relief. But at this point, the surgical team did not feel like they had anything to contribute. Even the surgery is the primary treatment for MPMs. They thought the disease was too advanced for any sort of surgery to help her. And so after a discussion with family and after goal care discussion, the family and the patient opted for hospice care. So with that in mind, I think it's important. This case is kind of important because MPM is one of those things. It's super rare, so it's never on any differential. But when you see patients with non-specific symptoms and especially someone who has had some weight loss, it might be worthwhile to consider some imaging, which could have helped her if we had gotten the imaging earlier. And Also, this is a very atypical presentation, like just the pain, because she never complained of shortness of breath until it was very much later in her course. And normally we can treat MPM with surgery, chemotherapy, and radiation, depending on the staging. But she was way too advanced to get any sort of treatment. And but yeah, something to keep in mind, especially when we see patients with non-specific symptoms and we can't quite delineate what exactly is happening. And any questions?
Thank you for your great presentation. I did have a question. Did the patient have any family history of cancer, specifically lung cancer?
No, there was no family history of lung cancer. And we also, something interesting, because obviously whenever we think of mesothelioma, we think about asbestos exposure and other stuff, other exposures. She was never like, we couldn't like find any particular source. Her husband did work in like a factory that kind of handled asbestos, and she said that she used to do a lot of laundry of her clothing. Maybe, maybe not, who knows, but we couldn't locate like a very specific source for her mesothelioma.
That's an excellent point. So this patient, didn't have any, may not have exposure to asbestos, but still has mesothelioma. Is that kind of what you're saying?
Yeah. I mean, she could have had it in her childhood, who knows? But like, based on what, like, no one else that she knows and is an acquaintance with has had mesothelioma, and she could not recall anything that would have caused any additional asbestos exposure.
Okay, great. Are there any questions from the audience at this point? Okay, thank you. Next presentation.